Hello, everyone. My name is Larissa DeLuna with the American Heart Association, and we'll go ahead and get started with today's webinar. Welcome to the American Heart Association's Stroke Webinar Series. These educational webinars are being brought to you by the Southwest Affiliate Stroke Committee. Today's webinar will cover the highlights from the 2018 Acute Ischemic Stroke Guideline Update. For a full list of upcoming webinars, visit www.heart.org/SWA-quality. Before we get started today, I'd like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your line by pressing *6 or type in the Q&A section of WebEx. Although this event is not accredited for CME or CE credits, attendees will receive a certificate of participation as proof of attendance. All slides, handouts, and participation certificates will be sent to attendees within 2 weeks of today's call. Also, please visit www.heart.org/SWA-quality to review a recording of today's webinar. Now we'll return it over to Deb Moats, the Senior Quality and Systems Improvement Director for the American Heart Association, to introduce today's speaker. Deb, you can *6 to come off mute. So I'll go ahead and introduce today's speaker. Today's speaker is Debbie Summers with St. Luke's Hospital from Kansas City, Missouri. Debbie was actually on the writing committee for the new guidelines. So Debbie, we'd like to turn it over to you.
Okay, Deb and Larissa, thank you very much, and glad to see we have so many attendees. So as you know, when you look at the document, there was many people on listservs, different listservs, saying this is over 300 pages. So we have amount of time here to kind of go over, and I'm going to try to emphasize the best practice and the most current guideline changes. So when we talk about the guidelines, Dr. William Powers was our lead author. There were several interdisciplinary authors. We all accepted topics relevant to the area of expertise. There was a very strict conflict of interest in that if you had some type of conflict in this, you were not able to be on the talk or on the conference. When we started that, we started this in September, I want to say 16. We were every week we were on conference calls. So if you did have a conflict of interest, you were not allowed to be on that particular topic and could not vote. There was very strict draft guidelines that were performed. We had 4 expert peer reviews, Stroke Council Scientific Statement Oversight Committee, and then the Stroke Council Leadership. The next slide just shows, and that should say, is the writing group of acute ischemic stroke. It says AID there. I thought I caught most of these. And when we look at the individuals that were invited by AHA to participate in it, we had emergency room physicians, neurologists, interventional radiologists, specialists in neurology, intensivists, and a nurse. So when we look at the guidelines, in addition to, there was 2 independent reviews that took a look at 2 PICO questions that we voted on and talked about, and those PICO questions were looking at thorough research. Was there science-based evidence on these 2 questions? And the first one was effective dysphagia screening strategies on clinical outcomes after stroke, and then the accuracy of prediction instruments for diagnosing large vessel occlusion in persons with suspected stroke. Dr. Eric Smith and Dr. David Kent led this group. They did their own independent research, and they have written 2 additional documents that you can find under the scientific statements that go along with the writing. When we look at stroke, we know that stroke has dropped from number 4 killer to number 5. It still kills more than 130,000 every 40 seconds. Although stroke is number 2 cause of death worldwide, there are more than 690 strokes, acute ischemic strokes due to blood clot, and 1/3 of these results from a large vessel occlusion, which we know causes severe damage and higher mortality. American Heart and American Stroke Association, I have to say, they have not rested in this determination to try to beat and treat acute ischemic stroke. And that they put individuals for American Heart were on our team every time we had a conference call, did a lot of help. So they really invested in creating the conference calls. The conference calls are based on more than 400 studies and contains revisions to the previous guidelines. And when I talk about that, you'll see on what guidelines were updated. There was some updates to 2013. This is the most current now. The inclusion and exclusion from the 2015 TPA scientific statement was basically incorporated into this guideline. We updated the FOCUS EBT guideline from 2015. The rehab guideline was looked at. If there was any new science on the rehab from 2016, that was included along with primary prevention. So these were based on the 2015 class of recommendations and the level of evidence. Recommendations, there are 62 new, 42 revised, 55 reworded, and 55 unchanged. And these recommendations cover from pre-hospital all the way through the different parts of it till prevention measures that should be instituted within the first 2 weeks. It does not address cerebral venous thrombosis. That was in 2011 statement, or children. So if we look at the class of recommendation, just briefly, you guys can always pull this up and look at it. And this is a little tiny slide, but you can always find it under American Heart. It's the 2015. So class of recommendation and level of evidence. A 1 is strong or very much recommended. A 2A is moderate, reasonable, beneficial. A 2B is weak, might be reasonable, should be considered. So there's a different level because there's less scientific evidence. A 3, no benefit, is a moderate in that, it would not be reasonable to use. And a 3, harm, is very potentially harmful to patients. And then if we just briefly talk about level of evidence, level A is high quality evidence for more than one randomized control. BR and R, always remember, is randomized, so it's moderate quality evidence from one or more. A was more than one. B and R, these are not randomized, so it's moderate quality from evidence of one or more well-designed studies, non-randomized, observation, registry, or meta-analysis. C, LD, is limited data, still from the randomized, non-randomized observation, and the CEO still is expert opinion. So when you're looking at the guidelines, just the format, you will see that we had a recommendation, we had a class of recommendation, we have a level of evidence, and the recommendation was what was it unchanged from, what original guideline, and then we had a 250-word knowledge bite. So that 250-word knowledge bite was probably the hardest thing because I tend to ramble when I write and talk, of getting that into the most important thing. And then you will see the tables of evidence. And this is the first time you've probably seen that. But as I went through the research on the area that I wrote on, I had to develop a table of evidence, showed how many clinical trials were randomized, how many were non-randomized, had to look at primary outcomes, had to look at the evidence, and summarize that in. And that is really the largest part of this, but you can quickly, well, you can go to that area instead of having to go to PubMed and pull that up and get a synopsis and decide if you want to read more of a certain article. So saying that, we're going to move, that was just kind of a brief explanation of what we did in setting this up and how it looks different to all of those who've been so used to looking at the 2013. So the pre-hospital guidelines, or the pre-hospital system, the public education was revised in that we know that there has been some randomized, moderate randomized, showing that blacks and Hispanics particularly have lower stroke awareness than the general population, and they are at increased risk of hospital delays in seeking care. So we're encouraging you as programs, when you're looking at going out into community, we need to develop over time and design to reach racially, ethnicity, age, and sex diverse populations. Also, when we look in the United States, we found that people of whites and women in non-urban areas, EMS was on 15 minutes longer in patients that were 65 to 74, whites and women in non-urban areas. 52% of the cases were identified by dispatch by stroke. If we look at then EMS assessment, we have a core 1 and level end of evidence of B, non-randomized. This is that identification of the stroke. So these are stroke screening, FAST scale, Los Angeles Pre-Hospital Stroke Scan, Cincinnati Pre-Hospital Stroke Scale. And by utilizing those, we know that we have a higher identification of properly identifying a stroke. Pre-notification to the hospital is also very important. And I don't think about that some people don't get notification, but in the latest Get With the Guidelines data, 67% of stroke patients, 67% of those stroke patients had pre-notification by the EMS. So it would be important to look at your own area and what is your area. And just briefly, and you guys will have these slides, pre-notification increases the likelihood of TPA within 33 minutes, 3 hours, the shorter door to imaging, shorter door to needle, and shorter symptom onset to needle time. And just to clarify, some of these slides, I'm going to not read all of them. You guys are going to be able to read them. I tried to be as inclusive as I could in this presentation, but we have slides on there that I'm going to just say there's more for you to look at. As far as regional systems of care, it is important, and we all know the importance, and that is the level of evidence A, of identifying regional hospitals that give ALTEPLASE and those that can perform thrombectomy. You will notice also I will try to always use ALTEPLASE. That was strictly that we went through. There's been some new black box and different things that we should no longer use TPA, not use the term TPA, forgive me, but we should change all of our order sets and everything that we use ALTEPLASE. You will find in the article when you're reading it, when it's referring to the NINS TPA first article, then we use NINS TPA, or if it was referring to some of the original articles, but it was very insistent that we utilize ALTEPLASE in all of our writing. Being transferred to the closest health care that can administer IV ALTEPLASE, it's not as much evidence. And then we know that by the benefit of bypassing the closest to bring the patient to one that offers a high level of stroke care is uncertain. That was a new recommendation that was written in. You know, there's a lot of controversy. There's a lot in my city. You know, there's like 12 primary stroke centers, 3 comprehensive centers in our city. And there's a lot of people at the table saying you should bypass them and bring them to the higher level. It's uncertain yet. We don't have enough data. And then, of course, every region really needs to customize their own algorithm to kind of account for local factors. So one of the ways, if you're not aware, and I would think if you've been on any conference calls, American Heart Mission Lifeline has proposed a severity-based triage algorithm, and that's the picture to the right. Prior to this paper being published, Turk and al. Demonstrated in published numbers, they showed that no single stroke severity tool predicts large vessel occlusion perfect. There's at least 6, and you should go to that data supplement that was written by Eric Smith and al. To really look at that. In looking at Turk and al., they demonstrated numbers that result, when they looked at a result in loss of greater than 20% of patients with LVO to be inappropriately sent to a center lacking endovascular treatment. So if you, though, looked at lowering that number of when they did these scales, and that's what the 10%. So if they looked at lowering, they reduced the false negative rate to 10%, and this would result in sending almost every patient to the Comprehensive Stroke Center. So it is very complex, and it's something that a large center that I'm involved with that has close to 1,600 patients, it's fearful for the large comprehensive stroke centers to see them all. So, and when I say you need to look at your own region and determine what tool you're going to be using, and then educate your EMS. There was also organization of integration of components and stroke system of care QI within the paper, and basically unchanged, but important, which I know as stroke coordinators and lead persons at your hospital, you are taking care of regional system, organization of all these components, and you're doing the stroke system of care QI. This is just one of the published studies, which was the large vessel occlusion. So this also shows the ones they looked at, showed the primary outcomes, secondary outcomes, and at this time there's insufficient evidence to recommend one scale over the other or a specific threshold, as I talked about, the 20, greater than 20%, less than 10%. Of additional travel time, which, and also we don't know the time to bypass a PSC or an acute stroke ready hospital. We don't have the evidence. Next, we'll look at hospital teams. And there's, I basically put in the new recommendations. It is very important still to have stroke certifications. There's some great knowledge bite information that shows that stroke certifications shows some difference in between the different certifications that people can obtain, whether it be Joint Commission or one of the others. We know that a stroke certified center increases and gives more additional TPA. The recommendation from 2013 was door to needle within 60 minutes in greater than 50% of acute ischemic stroke. The new recommendation is maybe reasonable to establish a secondary door to needle time of achieving door to needle times within 45 minutes and greater than equal to 50% of patients with acute ischemic stroke who are treated with ALTEPLASE. And this, the evidence has to come from the expert opinion, and that when you look at every single smaller anecdotal and different data that we have, patients had better outcomes. And this is, you know, going to be a very difficult to do a randomized control trial. No one wants to do that, nor would it be appropriate to determine, you know, in those patients, because we know tissue is brain is time, and time is tissue. It's also very important, there's a 1A, that when you have multi-component quality improvement initiatives, which include the ER, the multidisciplinary teams, access to neurological experience, this increases safety of giving IV TPA. And moving on, the telemedicine, the new recommendations for telemedicine was it can be effective for correct IV ALTEPLASE eligibility decision-making, and as to benefit those stroke centers, it's helpful in making decision support. Telephone can be a part of that. That was helpful to community physicians, and it was reasonable to make triaging decisions for acute mechanical thrombectomy centers. And it was also very useful, and this was a revision, that it would be good and useful in supporting rapid imaging resources. Some of our primary stroke centers have rapid imaging. They may not have the resources 24-hour to read that, and we can do that through telemedicine. Data repository was another outline or component of the paper. The new recommendation is that participating in stroke data repository is recommended to promote consistent adherence to current treatment guidelines, allow continuous QI, and improve patient outcomes. I would also mention there are comprehensive stroke centers that may not be academic, as mine is not, but we are involved in a lot of research. But some of the registries have been out there, have given us an opportunity to really increase the amount of research. We have always been very active and did all the mechanical embolectomy trials and the early TPA, and we've been doing research. But if you're not, having some of those registries can really involve your team and help look at your data. As far as the emergency evaluation stroke scale, the National Institute of Health Stroke Scale is the preferred severity scale. It's rapid, accurate, reliable, and can be performed by a broad spectrum of providers. It is also very accurate in predicting large vessel. A score of greater than 10 showed the sensitivity of 73% and a specificity of 74%. A score of greater than 6 showed a high sensitivity and not as high specificity. So there was a low threshold misses, some cases with LVO, but low specific indicators, so there were more false positives that occurred. I work with an EMS team in the past that has used the NIH stroke scale, but most EMS teams look at this as a more in-depth than they have time definitely to do in the field and to do it before they get to the emergency room. If we look at emergency evaluation imaging, the new recommendation is patients should be imaged in less than or equal to 20 minutes of our ER in at 50% of the patients who are candidate for ALTEPLASE and for endovascular therapy or EVT. In this, non-contrast CT is adequate in most cases, and we'll touch on that in additional. If you're uncertain about clinical stroke localization, there's some other things that you just need to know more about. Then, of course, moving to a diffusion-weighted or an MRI may lead to change in treatment, improving outcomes. The next one we look at imaging, there was some newer revised imaging. When we look at these, there's insufficient evidence to identify a threshold of acute CT hypoattenuation severity that affects the treatment response to IV ALTEPLASE. So it should not be used as a criterion to withhold. And when we looked at the NINS data, there was no interaction between treatment outcomes and like a dense MCA either. So actually, we should not withhold TPA because of a dense MCA. Additional thing that was brought into was which our program does not, but the routine use of an MRI to look for cerebral microbleeds before administration of IV ALTEPLASE is not recommended. So I guess that has been found that some people would do an MRI, and if they saw the cerebral microbleeds, that would be a reason to exclude IV TPA. There was 2 meta-analyses that we reviewed. These patients do have an increased risk of symptomatic ICH. However, it was not more common, like the 6.1% in one analysis, 6.5% in the other, than in NINS of 6.4%. Some other emergency evaluations, and these are helpful, I think, for teams. You should not do multimodal CT and MRI, including perfusion images. In other words, we do a non-contrast CTA, determine patient eligibility, give the IV TPA, and take the patient back for our imaging. I know many teams, the radiology department doesn't want you to do that, but you have strong. It is harmful to delay IV ALTEPLASE. In addition, to do non-invasive intracranial vascular study before trying to determine if they're eligible before giving TPA is also harmful. Or non-invasive if eligible, but do not delay IV TPA. It is, we need to do a non-invasive, so a CTA. But here again, I would say get the TPA administered and come back. We also, if there's question, you do not need a serum creatinine concentration in patients without history of renal impairment to proceed to a CTA. Extra cranial carotid vertebral provides us more information in procedural planning. Here is where the perfusion imaging for selecting patients in endovascular in less than 6 hours is not recommended. So in other words, make our decision in less than 6 hours on a CTA. There is a need for additional randomized control in this, but it gave really no benefit to get a CTP. In patients in the window of 6 to 24 hours, then obtaining a CTP, DWMRI, or an MI perfusion was recommended in patients selected for endovascular, and we could still utilize and benefit from more trials, but the randomized control trials showed benefit strictly in that range of 6 to 24 hours. The other thing, and your team may be looking at some collateral flow when you're doing your multimodal imaging, it's reasonable to include that into your decision making. So imaging in that first of 6 to 24 hours in anterior circulation perfusion is recommended to aid patients in selection. And I'll go over more of this in just a moment, but that came from our 6 randomized controlled trials, and they're listed there. DAWN was 6 to 24 hours, and diffuse was 6 to 16 hours. So, and when we're beyond the 0 to 6, we need to strictly apply the evidence from the science in selecting those patients. So in saying that, I'll talk about more of that when I get to endovascular. As far as emergency other treatment, it still remains you only need a blood glucose. You do not need to wait for coag testing and giving prior to TPA. Treat it less than 60, and the reasonable blood glucose range is 140 to 180. We are really lacking new science in that. You do not delay IV TPA to get a baseline EKG, ECG, baseline troponins, or a chest X-ray unless there is question that there is something acute pulmonary or cardiac disease. ABC supplemental oxygen did not change. The hyperbaric is not recommended, and looking for source and it is actually no benefit for hyperbaric. You have patients ask that because they go out to the internet and they read about that. Look for a source of hyperthermia is still a benefit, but the benefit of induced hypothermia is not well established yet. Hypotension and hypovolemia should be corrected to maintain systolic level pressures to support organ function. We really don't know what the blood pressure level it should be. There's no guide on volume or duration, so you'll see that was expert opinion. The blood pressure range for prior to ALTEPLASE has not changed, the less than 185 over less than 110. What was added was if endovascular treatment is planned and no ALTEPLASE is administered, it is still reasonable to maintain less than 185 over 110. And the use of drug-induced hypertension is not well established. The main drugs that are still used to decrease blood pressure, needing labetalol, nicardipine, clobazepine, and only sodium nitrite if blood pressure greater than 140. So we're going to talk about emergency treatment of ALTEPLASE and look at that. Basically, that was unchanged in the 0 to 4 hours. Just as a reminder, in the 3 to 4.5 came from the ECAS-3, and it included those patients that we have been aware of in the past. Some new or revised recommendations were to treat mild stroke presenting within the 3 to 4.5 hours. This gives a little more, we have a lot more data on that, not non-randomized. We still have questions. We know Maris is working that clinical trial or registry is addressing that. As far as cerebral microbleeds on an MRI, a small number of 1 to 10 still had just a BNR, and if greater than 10 might be associated, but as I said in that prior slide, they very much compared to the NINS data. A new recommendation was to treat with known sickle cell. Abiximab should not be administered with IV ALTEPLASE. It is harm. We should not administer ALTEPLASE if patient has received low molecular weight heparin in previous 24 hours. That was also harm. And the risk of antithrombotic therapy within 40 hours, or within 24 hours after treatment is uncertain yet, but you should refer to Table 6. It really took every single inclusion and exclusion that came out with the 2015 update and has included that. And I'm just going to, the next 3 slides, I'm not going to go over them. The team that presented nationally last week said I could use these so that you kind of see what the level of evidence is. And so these were all indications class 1 of level of evidence. And then there's contraindications and their level of class. And then were there additional recommendations, class 2A, and then class 2B. So that kind of divides it up if you want to use these, but they're all from that 2015. Additionally, the sonothrombolysis of utilizing was proven to have, as an adjunct therapy, had harm. Even though randomized, it was recommended not do it. The only, as far as IV thrombolytics, all except IV ALTEPLASE and tenecteplase is unproven. There are a couple trials there that you can go look up. Tenecteplase was from Nortest, and I believe there's one additional, And what I would say is your Genentech reps are not able to talk to you about this, but your liaison, your scientific liaison personnel from Genentech can talk to you more about this. But ALTEPLASE is a 1A and TELEMEDICINE is a 2B with a randomized trial. There was no basic new news on admitting to the ICU or a stroke center, blood pressure, neuroassessment unchanged. I know many nurses would have hoped we could come up with something, but there's no scientific evidence done on that. And then as far as delay of putting in catheters, if we can be maintained without them, and we should have a CT MRI at 24 hours before starting anticoagulants or antiplatelets. The clarity in management, there was additional tables that were added to this, which is Table 8 and Table 9. In the 2013, these were not in there. So the Table 8 is symptomatic ICH occurring within 24 hours after IV TPA. In addition, a new scientific statement came out, and I put that reference there because I think this went, it was right at the end of 2017, November, and I don't believe it made it in. There were so many references, I'm not for sure, but you should, if you're not aware, read that full scientific statement. In addition, the oral-lingual angioedema associated with IV ALTEPLASE was described in treatment in Table 9. What's new? This is from the 2015 focused update with endovascular. So let's take a look at that. We know that patients eligible for IV TPA, they should receive IV ALTEPLASE even if endovascular is being treated. That is a 1A. Patients under consideration for mechanical thrombectomy observation after IV ALTEPLASE assessed for clinical response should not be performed. In other words, you hear questions and you hear teams say the docs want us to wait 30 minutes, they want us to wait an hour, they want us to wait a certain percent of the time before we go to endovascular. But these patients should go, we take our patients, and this pretty much clears that up, that can cause harm. And what they looked at was the pooled data from all the 5 trials of the Hermes, and they found that time is the most important. So by the time you take that patient to endovascular, get that patient growing stick, and usually you've got your TPA in, but it is harmful to wait after IV TPA to assess for a clinical response. In the patient selections in the 0 to 6 hours, these basically are the same recommendations from the recommendations in the 2015. So I'm not going to review those because these are the 0 to 16 hours with a stent retriever. I believe that was the change in that we know stent retriever, it may have been, that may have been on there, but the stent retriever is the most, the tool that should be used in our mechanical thrombectomy patients. Some guidelines that support further exploring additional limits. We are unclear in the patients up to 6 hours whether it's helpful in inclusions of an M2, M3 branches, occlusions of the ACA, the vertebral, basilar, the PCA, a low aspect score or a low NIH-6 stroke scale, or if that baseline functional status is greater than the modified Rankin. We need additional research in this, but all of these are cases that I know if you're a center that does it, you can only go with the tools out so far. In M2 you can, but we've all had cases, but we don't have a lot of data. But it is a BR, so there's moderate, and there's at least one randomized that looked at it. Now, in the patients with selection of 24 hours, 6 to 24 hours. So just to clarify, I want to make sure we needed to divide this up into two categories. So our two clinical trials that have completed, and we waited on publication to get data. We worked with these teams. They were great, and we all had to have tape put over our mouth. We were excited, and those that were involved, I know you were. But patients within 6 to 16 hours, and we chose 6 to 16 hours of last known normal who have a large vessel occlusion in the circulation, meet DON or diffuse eligibility. Mechanical thrombectomy is recommended. That is a 1A. Because we had one or more, remember an A is high quality evidence from more than one. I said that wrong. So 6 to 16 hours got a 1A. In select patients with acute ischemic stroke within 16 to 24 hours who met the DON eligibility, it was a 2A with a BR. These are both highly, very good clinical trials, but the 16 to 24 hours had to be a BR because it was from one randomized clinical trial, and that was the DON. So in saying that, you need to learn the imaging, or your radiologist and your team will have to look at imaging selection. I put this just briefly because both of these clinical trials, the 6 to 24 hours, utilize some difference in their imaging, as well as in 6 to 16, the diffuse. And I'm not going to spend time on that. I put in here the two clinical trials that you should look at and have your teams look at. These are highly selective trials with powerful benefit. They both showed great statistics in doing this treatment. So here again, then, before I move on to that next slide, such great importance of you developing your systems of care. As far as procedural, we want to reperfuse to a modified thrombolysis of a modified TICI 2B3. Time is the most important. Reduce our time to reperfusion, reduce door to groin. In select patients, anesthesia technique based on individual specimen can be utilized. I put the three small randomized trial that we looked at. Blood pressure less than 180 over 105 during the first 24 hours. And if they undergo EVT, it was reasonable to maintain it at that. Antiplatelet treatment in patients with minor strokes not treated with IV ALTEPLASE. Treatment for 21 days with dual antiplatelet, aspirin and clopidogrel. Begin with 24 hours. Can be beneficial for secondary stroke. That was new. And tiglachlor is not recommended over aspirin in acute of minor stroke. Anticoagulation, we know that safety and usefulness of short-term anticoagulation for non-inclusive extracranial luminal in a set of acute ischemic stroke, it is not well established. And the safety and utilizations of factor 10A inhibitors are not well established either. Emergent cardiac intervention, these were the useless of an emergency or an urgent CA when clinical indicators suggest a small infarct. If it's compromised with flow, in acute thrombosis, the surgical site is suspected. It is not well established, and the efficacy or emergency or the urgency is not well established either. Moving on, blood pressure management, and I put the whole thing in there, but basically we don't know exactly in patients who do not receive IV ALTEPLASE or endovascular and don't have a comorbid condition, it has not been shown that beneficial to lower that blood pressure less than 120/120. As far as in patients with greater than 120, the benefit of initiating the treatment of hypertension within the first 48 to 72 hours is uncertain. It is reasonable to lower that. The core recommendation was downgraded because we don't have enough science on that. And then here again, in patients with acute ischemic stroke who have comorbid conditions, it is probably safe to lower that at 15%. So looking at your patient, in addition, starting antihypertensive therapy during hospital of the patients with patients' blood pressure greater than 140 or 90 who are neurological stable is safe and was reasonable to improve long-term contraindication. So that was new, and we do not have the data to tell exactly what hypotension, hypovolemia, but we know that if it's hypotensive and hypovolemic, we should support, maintain systemic pressure to support organ function. Dysphagia screening, I know there's been a great amount of talk. I would ask you to read the supplement. We are not saying that post-stroke dysphagia is not. We know it's common. We know it's a risk of pneumonia. We know it's associated with patient outcome. But right now, there's insufficient data whether screening or protocols decrease death or dependency, but that does not mean screening is ineffective. Overall, screening is reasonable, and we know that if you're older, more comorbidities, presenting with weakness, speech difficulties, high stroke severity, these all have a higher risk. So the recommendations, we really have very limited data. This is dysphagia screening before the patient begins eating, drinking, receiving medication. There's limited data. It is reasonable to screen. There's limited data. We know that an instrument evaluation is going to be more. There's non-randomized trial, undetermined physiological reasons, and it's not well established which instrument should be used, whether it be the fiber optic, the endoscope, video. So in summary, quickly, there is just not enough data to say which screening is most beneficial, but we are not saying don't do dysphagia screening because we know it's still important. New recommendations, I'll just ask you to read this. We know that enteral diet should be started within 7 days, and we said that if dysphagia is reasonable to identify, initially use NG tubes for feeding in the early phase of stroke and place a PEG when it's anticipated to be longer, which was greater than 2 to 3 weeks. This evidence all came from the food clinical trial, which is a European clinical trial, and a Cochrane review analyzed this. We know that in Europe they have different admission and length of stay, and but we found the evidence. We were trying to make this also international, but we know that no rehab center is going to take a patient without a PEG. But I don't know where that will be, but we've put the data in. Prevention of DVT, intermittent pneumatic compression in addition to routine care. Aspirin hydration is recommended over other routine care to decrease it. In other words, the benefit of prophylactic dose subcutaneous heparin in immobile patients is not well established. So we had to download these. There's a lot of research that is shown, and I think the next slide, the benefit is not established in prophylactic dose. We do know there's no comprehensive stockings. That should not be used. Patients that had unfractionated heparin, low molecular weight heparin, had a higher risk of hemorrhage following. There's some new recommendations on secondary prevention. that these can be done in less than 2 weeks, 48 hours to 7 days. It was a revised and should be performed routinely within 24 hours of admission who are candidates for carotid endarterectomy. Rehab basically was unchanged. When they're looking at large supratentorial infarction, there's a few slides on here. I want to just go over quickly. Palliative care, we should do that, utilize it. When patients, we need to really introduce discussion and care option in these patients who have these high large infarctions. And we know there's been new palliative care statements written. I'm not going to, because I'd rather ask some questions. We had some revisions from the guidelines on 2014. So I've put these in. You can read them. Let me see if something just stands out, because they were the most revisions from the 2014. And then diagnostic testing. Diagnostic testing, we talked about the need for cost-effectively, only when it leads to a change in treatment that improves outcome. Unfortunately, there was not enough randomized data. We are not telling people to not do testing. I also borrowed this slide from the last talk, and we're not telling people to do testing, but evidence doesn't support routine. You need to look at every patient individually and identify, are they at risk and would it benefit doing an echo? Also, I always thought it was kind of, do we really need a blood cholesterol? If a patient's on a statin, blood cholesterol not on a statin, so there were some questions. I would ask you to read each of those kilobytes, the importance of why we did that, of these, and to try to conclude, so we have a few minutes, the world, and this was a quote by Dr. Jeff Saber, the world is moving from a time clock to a tissue clock. It's no longer just a time clock, it's also a tissue clock. And in closing, I know there's the email for HA that will be coming up, and I put one in here. But I know I went through some of those. I tried to cover the most important. We don't see as many of those cerebral edema and treatment, but you should take a look at those revisions, particularly if you're in the ICU. So I'm going to turn it back to you guys.
Thank you so much. Does anyone have questions? You can press *6 to unmute your line. And I'm seeing if we have any questions in the Q&A section of WebEx. But again, *6 to unmute your lines. And we did have one question if you can get a copy of the PowerPoint presentation, and yes, that will be emailed to everyone along with a recording of today's webinar and everything in about 2 weeks. All the attendees will get that.
Hey, Larissa, this is Allison.
Hey, Allison.
Hey, I just have a quick question for Debbie, and maybe, I don't know if she knows the answer or not. It was brought up to me in one of my recent meetings that the previous guideline had a lot more clear-cut direction on what labs should be done in the emergent phase during the, when the patient first arrives to the ER. And then in this new guideline, it is a lot more unclear as to what is recommended during the acute phase. And I wondered if Debbie had some insight into that, or if why they decided to take that information out.
Well, the only lab that we definitely need before giving TPA is blood glucose.
Okay.
I know that table is in here, and it could be a serum or it could be the glucose that is a peripheral stick at the bedside. We are not saying don't get a troponin. Now, if the patient is on Coumadin, of course, you're going to need an INR. I think that was clear in there. but we don't have to have a complete blood count. We don't have to have a troponin. We don't have to have that lab work to give IV TPA.
Okay,
so
that's what I figured, but I wanted to make sure.
I believe everything else is, and I don't know which, well, I say the table's in here. I've been going through the paper, and I've got it all into several different stacks here today. So I couldn't tell you if that table's in there as many times as I've reviewed this. But that was a guideline, and so you would go ahead and complete an electrolyte. You would complete, but it should not delay giving TPA. Many people have point-of-care testing for an INR now. So you should, if you use point-of-care testing, you would have that quickly. You don't need a CBC, unless you should always, in all of these, look at the patient. If there's for some reason that, you know, the patient says, well, I was in the hospital or, you know, 6 months ago and they thought my, you know, something that is specific, and that's the taking of a good history. But time is brain, time is tissue, and the 1A was get a glucose.
Thank you so much, Debbie.
Any more questions? You can press *6 to come off mute. The only other question we had via online was about getting a certificate of participation. And yes, that will be sent to everyone in about 2 weeks with the slides and the recording link.
And I would like to ask the participants if there's something, like in giving this 1-hour talk to probably primarily nurses we have there, something that you would see that's very important that maybe should be talked on more for nurses, or I'm working with AHA and will be, the next task will be to review the nursing guidelines. Actually, they can't be called a scientific statement, and we are not to repeat things that have been, so we're trying to really, what is needed for nurses. I've heard good things. I've heard bad comments on people like the short sound bites, we call them. Some people like missing out on the more detailed explanation. But in doing a 1-hour talk, if someone has some great, I welcome comments because I've been asked to do this another time and probably will get the privilege to speak to more people off and on. But I welcome your input on, you know, I tried to look at it and just talk about the new and revised, or and some of them we didn't talk much, or we didn't change much, so I left those out. But I would take any feedback and appreciate it very much.
Debbie, I think you did a great job. This is Alicia with Comanche County Memorial Hospital, and I do have a question. I think, and I don't know if you guys can help with this, but I think that it would be really valuable to our stroke system of care throughout our state if we can help establish an algorithm, a transfer algorithm of how to look at these patients in that 6 to 24-hour window, and how to best be able to get them, you know, get them the testing that they need and what the comprehensive centers need to be able to ship them out, so that we can just identify the patients that would benefit from the treatment, and the ones that wouldn't, if they, you know, their perfusion rates are really low and they're not great candidates, then for them to stay at that facility so that their families can still be a part of that rehabilitation care.
Yeah, that's a great comment, and a lot of questions that could be asked or answered. Mm-hmm. I would take a look at we updated the mission. I'm on the Mission Lifeline Committee. We updated that algorithm. I think, well, I know I have the most one in here, but take a look at that. I couldn't go over that, time to go over that, okay, and sit down with your different teams and look what we put in there. Now, I'm in rural Missouri, basically. I live in a large metropolitan city, not as large as some of you live in, But we're basically rural. We have 3 comprehensive centers in our city, and then we have 12 primary stroke centers, and then we bring patients from 100 miles out from what are called critical access patients that have critical access beds, which have 25 beds.
Mm-hmm.
These centers do not, as well as I know of large number of you in the Southwest, they're never going to buy a rapid perfusion or some kind of CT modality. They don't have the money. They don't do the number of strokes. So determining, and we don't know the best, there's Mission Lifeline is looking at having data points that we want to start gathering down the line. There's some that are already trying it within EMS, trying to determine which one of these large vessel occlusion scales through registry has proven to be the best. But first of all, look at your team, ask the EMS what large vessel, go through them. What might be the best one that they would utilize? And that I know Dr. Yauk and that whole area in Carolina has chosen RACE. I know other people are using VAN in regions, but you need a region that pulls together and teach all the EMS, get their input, let them look at it, and what are they going to use? And you're going to have to create kind of that algorithm, pull that paper out, what's the specificity of it, what's the sensitivity of it. In the metropolitan area, we have a couple of hospitals that are primary stroke centers that are purchasing perfusion, quick perfusion data, software packages like Rapid, and there's just a new one that's been FDA approved that's out there, going to be coming to the States. And they have, when we had a poster there in the community, and I can't exactly remember, but they were shipping so many patients to our center that did not need endovascular therapy that they chose to buy it, and I wish I knew those numbers. It was amazing. Out of 30 patients they shipped to us, 28 got intervention. They kept a lot more patients at that institution, which financially, and then those CEOs of that program, they are so willing to work with us to ship the correct patients. So when I talk about regional and within your center, you know, is it going to be, you are going to have to do some of that data. How many patients are being shipped to you that you're not doing? Maybe they're shipping a lot to you, but it would benefit them buying that software package. I don't know that any of have answers, but a lot of things going on and trying to help create, you know, appropriate, you know, patients that come, because as a comprehensive stroke center, we don't need any more some days.
Right, and we've talked about the Rapid for our facility, but you know, money is always an issue, of course. And so one of the things we were talking about is if the patient had a CTA head within that time frame, and then to do an MRI fusion, because we do have that capability, and then they could see whether or not. Sorry.
If you could get it rapidly, and I believe that, and I know we do what's called a rapid MRI, which we, and I can't remember if we, I don't know if that's in the paper, but we do just a really circle Willis.
Okay.
So we do a fast MRA is what we do. So we don't do, no, because we have CT perfusion. I'm sorry, I got that mixed up, so apologies. We do if we're a hospital that may have an MRA, we tell them, and that's some of our smaller hospitals here in the city, do just looking at the clinic, you know, the circle of Willis and looking at those vessels. So I got off on a different point. But.
Okay. Awesome. Thank you.
Yes.
Well, thank you all for staying on. We've ran a few minutes over, but Debbie, we can't thank you enough for taking the time out of your schedule to go over these guidelines and review them with us one more time. If you have any other questions or anything else that you need, feel free to email us at swaquality@heart.org, and look forward to sending y'all the email with the slides and your certificates of participation. Thank you everyone so much, and have a great week.
Thank you very much.